A recent study out of the United Kingdom tracked women's spending habits and accurately identified the symptoms of ovarian cancer based on the customer's purchases. It's a level of tracking that people often balk at, feeling all too surveilled in this technological era. But could this tracking save lives? Let's ask. In London, UK, one of the leads on that study, James Flanagan. He's an associate professor, or as they say in the UK, a reader in epigenetics and data science at Imperial College London. And here in our studio, bioinformatician Emma Bell, who is a postdoctoral research fellow at Princess Margaret Cancer Centre, and Sunil Johal, the David and Ann Wilson Professor in Public Policy and Society at Victoria University at the University of Toronto. And it's great to have, Sunil, you back here. Emma, I think you for the first time here.
Yes.
And James Flanagan, thank you for joining us from across the pond. And I want to start with you. Why don't you just introduce us to the idea of how your study worked to begin with?
How it worked. We started this study, the idea for it started in what's known as a sandpit event, where we come up with crazy ideas to address big challenges. And the big challenge that we had was to use big data to help earlier detection of cancer. We came up with the idea to look at shopping data to try and find out what cancer patients were buying before they go to the GP. We want to shorten that time between when patients identify symptoms and get to the GP, and then from there onto the cancer diagnosis.
So that's what you did. What did you discover?
So what we found, we recruited 153 ovarian cancer patients and 120 control participants, women without ovarian cancer, and we looked at their data going back up to 6 years before the diagnosis. And we found the ovarian cancer patients were buying ovarian pain medication and indigestion medication up to about 8 months before their diagnosis. This was around about 4 to 5 months before they would go to the GP. So they're treating or managing these symptoms for many, many months before they recognize them as serious enough to go to the doctor. The idea of using this data, obviously people can be concerned about tracking and monitoring this data, and it's important to remember, first of all, with the study, that the participants had to provide explicit consent for us to access this data, and any possible monitoring of this data for this purpose would have to be an opt-in system. So people would have to opt in with their data to allow people to monitor it for this purpose.
And one last follow-up before I get our friends here in the studio involved. I mean, obviously, when you're talking ovarian cancer, early diagnosis is absolutely key, because you got a shot at living, obviously, if you can catch this early enough. How much earlier were you able to diagnose, tracking the spending habits of the people involved in your study than, say, regular medicine could?
So, as I said, the data suggested that the participants, the ovarian cancer patients, were buying these medications about 8 months before their actual diagnosis. This turns out about 4 to 5 months before they visited the GP, and even about 4 months before they recognized their symptoms. In our questionnaire for this study, we asked the participants, when did they first recognize they had serious symptoms of ovarian cancer? And that happened about 4.5 months before their diagnosis. So if we were monitoring this data and found a change in habits or a change in purchases or something going on for over a month where they're increasing their purchase of these medications, you might assume we could get to their diagnosis 3 to 4 months earlier than would otherwise have been. And with ovarian cancer, this is really important, because we know the later the diagnosis, the later stage cancer they're diagnosed with, and the poorer their outcomes. So we really want to get them sooner so we can improve their chances of a better outcome.
Okay, let's get some reaction here in the studio. You've worked with him before, yes?
I'm afraid so.
What do you think about the study?
I think it's very promising. There's a clear difference in the purchasing behaviours of people who go on to be diagnosed with ovarian cancer and those who do not, up to 8 months before diagnosis. This is something that's been widely speculated, like the change in behaviour, the uptick in purchasing Pepto-Bismol, ibuprofen. So it's really nice to see it demonstrated. But I caution that this is one of the first few steps on a very long road. So this isn't going to be rolled out tomorrow, 5 years, maybe 10 years. It's got a long way to go before it becomes an effective screening tool.
I got you, but let me put it this way. If you could, by doing this, have a 4.5-month extra lead time in diagnosing ovarian cancer, that would be massive, wouldn't it?
That would be enormous. 2/3 of ovarian cancer patients are diagnosed at stage 3, 4, by which it's spread widely throughout the body. If you look at the 5-year survival for those patients, it's about 30%. If you get your diagnosis at stage 1, it's 90%. So
4.5 months earlier diagnosis could mean what percentage more people would live?
Oh, I'm afraid I didn't do that maths.
We don't normally do math on this show, but suffice to say, a lot more people would live.
Yes, well, hopefully. It would get people into the system earlier, which means you've got more treatment options, and you've got more time. So yes, theoretically, this would lead to improvements in survival.
Now, you've been careful to say this is not the silver bullet yet. This is a step on the road. What are your concerns about the shortcomings of this approach?
Well, as James mentioned, this is approximately 150 patients in each group. While ovarian cancer does predominantly affect white people, there are questions about how we would bring this to all Canadians that need to be asked. So the study itself included about a dozen non-white people, is what they were classified as, in both the cases and the controls. So given that although ovarian cancer is more frequent in white people, Black people tend to have lower survival rates. There is certainly a need to make sure that we are including as many people as possible, as many Canadians as possible, as this goes forward. And there is a question about whether you can do that with loyalty card data. So if you look at who has a loyalty card, the majority of those people, they're going to be white, middle-class, cis women who live in urban and suburban areas.
So you have some questions around equity around the whole thing.
Yes, so it's a very self-selecting sample, and while we could definitely help those, well, we could theoretically help those if we get further along these road. What about rural Canadians? What about Black Canadians?
Okay.
What about Indigenous people?
I'm going to get, no, not at all. I'm going to get James Flanagan to comment on that in a second, give him a chance to respond to that. But first, we have you on this program whenever we like to talk data, or data, however you pronounce it, and this seems to be one of those shows. So that's why you're here. What do you think about what you're hearing?
I'm glad I'm not here to talk about cancer research because I wouldn't have had much to say. But I think on the data point, we're entering a world, and we're in a world now where data is all around us. We're swimming in a data-rich environment. Organizations, whether private sector or public sector, are assessing how they can extract and use that data, and in the case of private sector organizations, monetize that data. That can have potentially very beneficial impacts for us as Canadians and as citizens, but it also has potential significant risks attached to it. So I think we're at a time now where this data gathering has really picked up pace over the past decade or so, and legislative and regulatory frameworks are only now starting to catch up to where the data collection activities have gone. So it's a really interesting time for policymakers because on the one hand, we can seize this opportunity to deliver better programs, deliver more effective services. But on the other hand, we need to make sure we're doing that in a way that, to Emma's point, is done in an equitable fashion that protects people's privacy, particularly those of marginalized individuals, young people. And those are tricky questions because most of us in an online environment, when we go on our phone and download an app, we're just clicking through. We want to get the app. We're not looking at those terms and conditions. Do whatever you want with my data.
You don't read all 25,000 words of those terms and conditions?
I used to, but then I realized that's putting me to sleep and it wasn't working super well. So I think those are some of the challenges we're facing. Like, how are people giving informed consent for the use of their data, and how do we make sure that that's being managed in a fair and an appropriate fashion?
You've been on this program before talking, actually decrying the fact that we don't seem to have adequate data, in particular in the healthcare system, in ways that we need it. They collect a lot of data. What is it? Which is it?
I say data.
Okay.
You
I say
say
data.
data.
You say-
you say
okay.
ketchup. I say
Let's
catsup.
pull the whole thing
Yeah.
off.
Okay. Well, whatever we want to call it, you've often been critical of the fact that we don't either collect the right information or enough information. Is this an entry into potentially revolutionizing the way that we use information in the healthcare system to the benefit of the larger population?
I mean, I don't know if this particular study is that entry point. I mean, I think what we fundamentally need in Canada is we need the basic data infrastructure where people have a digital ID, we have electronic medical records, people can port their data between providers. Because I mean, generally speaking, when I'm in the medical system, I don't just see my doctor, I might also be seeing a pharmacist, I might be going to a hospital, I might be seeing specialists. I mean, I just switched my family doctor a few weeks ago. I was filling out paper forms and they're, I think, faxing that information over to my old doctor,
Yep.
they're sending it back to the new doctor. That shouldn't be happening in 2023. I mean, we have examples from other jurisdictions where you should be able to know who's got your medical information. You should be able to freely consent to this provider can look at these parts of my medical records, this provider can't, and it should all be digitized. And it can be done. Other countries are doing it. So let's get to a point where that's possible, and we're not faxing things back and forth, and I'm not writing my chicken scratch writing about who my old doctor's name was, and I might forget her name, and then God knows what happens if they send the wrong records, and they're treating me as an 85-year-old gentleman.
Which, if you're lucky, you will be someday.
I hope so.
Yeah, there you go. James Flanagan, let's get you back in here. You've heard some of the concerns that have been expressed here in our studio, particularly around issues of equity and equal access to treatments, security of information, and so on. Go ahead, take a hit at some of those.
So I'll start with the inequality or the ethnicity bias in the data. Obviously, this is very London-based and UK-based. We recruited a lot of patients from Wales, for instance, which is a very white area. And I agree, it's biased, and we should address that by trying to recruit participants from those minority groups. We are actually addressing that in our next study. We're working on a new study looking at new cancer types. And one of the areas that we're recruiting on has a very big Indian population. So, for instance, we're going to be translating some of our documentation into Hindi and various other Indian languages so that they can have the opportunity to participate and not feel excluded because they can't read the questionnaire. So that's one of the ways in which we can address that. We can also address it by recruiting more participants from Hammersmith Hospital, the hospital I'm based at, which has, for the ovarian cancer clinic, I think they have something like 50% non-white patients. So we should have tried to get more from our hospital here. So yes, there are ways we can address that. I think that's an important point. Coming to the sort of data security, I think it's really important that anybody who sees their data being used in this sort of research can feel that the data is held by a trusted source. Universities are typically trusted sources. Government, NHS in the UK, Canadian healthcare system, I'm sure, would be considered a trusted source. We know that people feel less trustful of private companies that, as you say, are using data to monetize it and to try and profit from your data. I think having a health outcome rather than a financial outcome might feel more trustworthy. And I think also about data security, we need to make sure the data is housed within secure environments. For instance, in our study, we were holding this data in what's known as the secure enclaves, which is a very secure computational environment that's not actually attached to the internet, so you can't actually get into it, only through our secure access points in my office right behind me. So it's very secure, and we tell our participants that, and hopefully they will trust us with the data. And I think any use of this data, wherever it is, other researchers needs to be doing it in a similar way. And just coming back to the point about data, there's a lot of data that's being accrued from medical systems, whether your GP appointments, pharmacies, as you mentioned. all of that data is all really important, and it should be collected in a centralized system if we want to be able to do research like what we're doing. But I just point out that our study is really about that point before you go to the GP. We want to decrease the amount of time it takes you before you as an individual decide it's time to go to the doctor, because we see that interval, that patient interval, as we call it, is too long, and we need to get participants, patients, particularly ovarian cancer patients, to the doctor sooner. So I think that's something that we're really hoping will come from this type of research.
Gotcha. I'm tempted to follow up with Emma here, who's also from the UK, on whether it's privacy or privacy, but maybe we'll leave that for another show. But in any event, to what extent do you think, I mean, this is all, groundbreaking and new. How worried are you that by tracking women's shopping patterns, we may get some false positives out of this as well?
Yeah, this is a serious concern when it comes to any screening effort. So the way that we diagnose ovarian cancer currently, we have transvaginal ultrasound, and we have looking at the protein, the blood levels of this protein called cancer antigen 125. Neither of those are perfect. They're not particularly specific. They're not particularly sensitive. Well, like the sensitivity and specificity is the key. So you are going to get some false positives, which means those people are going to end up with the mental health aspects of having to cope with, do I have cancer, and going through that diagnostic pathway. And any tissue biopsy that's taken, that's going to require surgical intervention. Anything surgery based, you've got a risk of bleeding, you've got a risk of infection, you've got a risk of pain. And you do see false positives coming up. So one of the challenges on this road is to minimize those false positives, because it's an unpleasant experience to go through, even if you have to. So we need to avoid putting people who don't have to through that experience.
Sunil, let me ask you a question about some of the ethics around this. For example, when we donate blood, in this country, for the most part, we are not paid. It is a voluntary service. Should the same hold true for data collection in this case?
That's a really interesting question. And I think it does depend on, is this for a corporate use? I mean, if I'm giving my data to Google and they're targeting ads to me, I probably have a higher expectation that I should be paid for that. If it's for a medical study, it's for something more of a public policy purpose, I think there's a stronger argument that this is in society's interest. We shouldn't necessarily be paying you for it.
It's your job as a citizen to do it?
It's kind of incumbent as you as a citizen to do this, and you're going to ultimately benefit from the better information we have about population health or whatever the specific realm may be. So I think the payment aspect, I don't think that should be kind of the thing that we chase down and should I get paid for this or should I not? I think to me it's more, is this being done in an appropriate, responsible, safeguarded way? And if people are profiting off of this in the private sector, then I think there's a much stronger argument that the data providers are being compensated for the provision of that data.
And let me do a follow with James on that. You talk about data donation in the same way that doctors or clinicians talk about tissue donation. So perhaps explain to us how that might work.
Yeah, it's an idea that's been talked about quite a lot over here over the last few years about what's known as digital footprint, or there's a lot of data that's being collected on you, whether that's data from your Fitbit, from your mobile phone, Googling search terms, shopping data, various bits of data. There's a lot of data that's actually being collected about you. And if we can use that for research, use that for health outcomes, and make advances, then it might help if we can link all of that data together. So we've been talking about the idea of asking people to donate their data, much like they donate their blood for the blood service. People do that regularly, and they do it altruistically. They don't get paid for it. And it's the same for data, I think. We need to look at it as an altruistic thing. where people would donate their data, sign up. Obviously, as I mentioned earlier, it's always got to be an opt-in. You've got to provide consent for this data to be used, and you can then link all of this data together and try and make new discoveries that will help us with the health outcomes that we're interested in.
Okay, Emma, a very problematic ethical question now coming your way. You ready?
Oh, okay.
Here we go. If we discover down the road some of the concerns that you've already put on the record, that this approach seems to favor white people over black people, is that a reason not to do it? In other words, the fact that we can only potentially help some people because of the problems you outlined, if equity issues prove to be a problem, should it therefore be dropped, or do you go ahead anyway?
It depends, which I know is a terrible answer.
But it's a nuanced answer, and that's the question.
So when you're making decisions about medical interventions, which drugs to fund within a healthcare system, you have a finite budget. So if you spend money on drug X, which increases the likelihood that a cancer patient is going to live a couple of weeks at a very poor quality of life, and that's one cancer patient, you're spending that money, and you cannot spend that money on anything else that may intervene at an earlier stage.
So it's not a win-win. Somebody wins, somebody loses.
Always. And our healthcare systems are prefaced on the basis that we're going to do the most good for the most people. So if we're talking about a finite healthcare budget and we're not serving all Canadians who are at risk of ovarian cancer, I think there's a stronger argument that we don't push forward and that we instead go work to educate patients on what the symptoms are, which, by the way, gastrointestinal issues, bloating in a postmenopausal person, that usually indicates it's a day that ends in a Y, but it can also be something much more serious. And there's the other half of the other side of that coin where we need to educate GPs better to recognize that collection of symptoms so that when the patient does come in with these complaints, with these changes in their body that they know if they know something's not right, that the GP knows, I need to take this seriously.
James, can I get you on that one as well? If you discover that this approach that you're taking will absolutely disproportionately help white people over people of color, is that reason enough not to go forward?
I think you would probably need to do a lot of research in those different populations to try and really answer that question. I don't think us as individuals can answer that question. I've always said that our study certainly doesn't help anyone who doesn't have a loyalty card study. So a loyalty card. If you study the people with the loyalty cards and discover something that tells you that can help you get to the GP sooner. So imagine that's buying indigestion medication and pain medication over a 3-month period, X number of boxes of this medication. Whether you have that loyalty card or not, we could have information at the pharmacy, for instance, that says, if you're buying this much medication, perhaps you should talk to your GP. And that would then reach those other people that don't have the loyalty card. So that's one way you could reach those people. In terms of other ethnicities or other people that don't have cards, if we were to show that this use of this loyalty card data can have health benefits, it might actually encourage people to get a loyalty card and start using it. So it might actually encourage people to get more involved in using that sort of thing.
Interesting. Okay, Sunil, oftentimes when there's a breakthrough of some kind, there are, almost always unintended consequences people did not see coming down the road. As you think about this, do you see any unintended consequences potentially?
I think James might have just hit on one with his last comment there, where it's the situation where maybe I need to get a loyalty card and start shopping with certain chains so I can get better access to healthcare, because those are the people getting filtered through the system
That'd be a very
effectively. And
happy consequence for some retailer.
might be good if you're the Boots. I don't know if Boots still exists in England, but they did when I was okay. Good. Or Tesco's. I'm naming random British stores now, but I mean something like that could theoretically be an unintended consequence. And I mean we've seen in the past that sometimes tracking population level data or quote unquote big data seems to be ticking along quite well, and then for whatever reason the algorithm kind of goes a bit wonky and it doesn't work. I mean, Google Flu Trends was a good example of that. I don't know if you remember, a number of years ago Google was putting out reports about search terms that people are using for things like I need Tylenol, and that'll track on what the flu rates are in a population. But they had to discontinue that service after a while because the algorithms weren't working very well and it was getting kind of clouded with other information. So, I mean, I think there's all kinds of potential unintended consequences that have to be monitored, not just by the provider, like the research institution in this case, but like who are non-involved parties who have expertise in these areas, who can monitor, make sure that the data is being collected effectively, make sure it's still hewing to its intended policy or program objectives, and it can be terminated, adjusted, or otherwise altered if required.
We're obviously, Emma, talking about ovarian cancer here, but do you think this approach could also work with other types of cancers?
Yes, certainly. So ovarian cancer is one of a selection of sort of more internal cancers that have poorer survival. So cancer survival has increased from about 25% over a 10-year period to about 50% since the 1970s.
That's all cancers?
For all cancers. Ovarian cancer, pancreatic cancer, of course, I can't remember the rest off the top of my head right now.
Esophageal?
Oh, yes, I bet you. Sorry.
They're still almost death sentences.
Yes, essentially.
Yeah.
If you get diagnosed with ovarian cancer, eventually you are going to become resistant to the chemotherapies that we currently have available. Thankfully, there's a lot of work being done to provide a wider range of chemotherapies, but still, it's not a great outlook now.
Right.
But if we diagnose at stage 1, when we have a 90% 5-year survival rate, we're giving those patients potentially a better quality of life over a longer period of time. And I think that's certainly worth fighting for.
Amen. James, in our last 30 seconds, tell us about what your next study of interest to our viewers will be.
So we've been funded to continue this work with a new pilot study looking at some of the new cancers, some of the ones you've just mentioned. Esophageal cancer is one that has indigestion, is actually a really serious symptom of that cancer. Cancers like pancreatic cancer, liver cancer, stomach cancer. We'll be looking at about 10 new cancer types to see if monitoring purchases can identify symptoms before these patients go to the GP. So we'll be doing that in the next 12 months or so, and hoping to build on it from there.
We should get this group back in 12 to 18 to 24 months and just see how things have gone. That was fascinating. James Flanagan, Associate Professor, or Reader as they call him over there, Imperial College London. We thank you very much for joining us on the line from the UK. Emma Bell, Princess Margaret Cancer Centre, Sunil Johal, Victoria University at the U of T. Great to have you two here in our studio as well. Thanks, everyone.
Thank you.
Thank you.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.